Any questions for Rupal? I can see that Frank has already started.
It's not really a question, it's only a remark. It's a remark that the procedure is very elegant and very efficient. Congratulations for the surgery. Question, will it replace excimer laser sooner or later? Maybe it's too early to tell, because we are waiting for other results coming out for different sites. Maybe yes, we'll see.
Any more, Jerome?
A technical problem that we had with some other femto, when you have a bridge on a normal flap, it's become difficult. With this size, if you have a bridge, how do you manage to cut the bridge on behind to take out
That's a very pertinent question. If you have an opaque bubble layer, say, then it becomes very difficult to dissect out that plane. But fortunately, I think the energy parameters that have been set and the high frequency and the smaller spot size helps us to avoid this problem. So up till now, I've really not had any case where I had difficulty in separation right from the beginning. And I've treated even low myopia as low as -0.75 diopters with a very thin lenticule, quite superficial. I usually make a 90 micron cap. I don't really make a thicker flap than that, so it does work well accordingly.
The gentleman behind your own, please.
Yeah, a couple of queries about things you said. You mentioned that the femtosecond laser will always cut. It either cuts or it doesn't cut. It's always in the same place. I would have thought that if the energy went higher, then the energy density required to get electromagnetic breakdown in the cornea would take place at a higher position in the cornea, because as the beams focus, you reach that breakdown intensity more quickly. Is that not correct?
It is. I think if I get your question correctly, are you trying to say that the predictability of the depth at which you do the procedure?
Well, you said that for excimer lasers, if the energy changes, then the amount of ablation will change, which I agree with. But I would have thought that if the energy of the femtosecond beam changes, then the depth at which you cut would change. Not a lot, but a little bit, which when you're talking about just removing a lenticule of tissue, which is only some tens of microns thick, it could have some effect.
So if you're talking about the predictability of the depth at which you can go, we have to consider that we are using the same cone, and therefore, however much you are decentered, the whole lenticule gets decentered, either below or above. So the refractive result doesn't suffer. The depth from the anterior part of the lenticule to the posterior part will always be predetermined. Whether you get it at 90 microns or at 100 microns, maybe that would depend upon the tear film and the energy breakdown. But it would still, between 2 layers, it's going to remain the same.
So the whole thing then moves up and down,
yes.
but the thickness remains
but the
the same.
thickness remains what you intend to.
Very quickly, you also said that somebody painted a room nearby and that prevented you from doing excimer laser surgery. That wouldn't bother you with femtosecond laser?
No, it would not. Definitely not.
We have, yes, from the audience one more, and then it's your turn. Vicente Rodriguez. Wait, microphone.
Result are very good too in the low myopia, for example, minus 0.75, minus 0.50 myopia with a little astigmatism. It's very good, the result. I think that is very, very interesting. Yes. For the correction of the middle and high myopia, but in low myopia and low
myopia also the results were the same.
Similar
to what you would have with exam.
When do you treat or retreat, we need to go to the surface?
For retreatment right now, we could either do a surface ablation Or there is a new circle software which they've been able to devise, and I tested it for them just a month back, where I treated 3 eyes. The circle software allows you to reach the same plane and also go a little beyond, so as to create a femtolasic flap. So you could actually open a flap, go to the same plane and do an excimer laser on the bed. But you still need an excimer laser.
Yeah.
What we are planning to do, or the thing that I have suggested is that since you are delaminating and not really creating a flap here, you could go to a slightly deeper plane. I've compared one eye 90 micron cap with 140 microns in the other eye, and I've seen a significant difference in the ORA results with a bias towards better results with 140 microns. So if you can routinely do a cap of 130 to 140 microns, then you could in fact open a whole flap on top, or if it's a small myopia, you could even take another lenticule from the cap itself.
About the presbyopia correction, what do you think about in the future? We can have a profile with this platform for the presbyopia correction?
Yes, in fact, towards the end of our study for the 50 patients that we've treated so far for hyperopia, with the newer profiles, the results were becoming more acceptable. But we had to stop the study because we were coming to an end of those 100 eyes. And then the company wanted to wait to make sure of the profile and again go through the ethics committee, and everything is taking a little longer. But I think we would definitely have some solution in future.
Thank you. One more question from the audience.
Случались ли у вас разрывы лентикулы при технологии СМАУ? И ваша тактика?
Okay. Fortunately, I did not have any ruptures. The separation is very easy, and there's also a side cut of the lenticule that happens. So when you're actually going in that plane, you tend to separate the same plane, and you don't really need to pull out. You can see the edge developing when you actually separate the lenticule. So unless you are sure you have a complete lenticule separated, you should not try to grasp and remove it. But so far, I have not really had a tear in the lenticule, even though the lenticule thickness was as low as 30 microns.
Final question, Jerome.
Thank you for your presentation. I had a question about retreatment, but you have already answered. Is the depth of the first plane is the same, or it varies in function of the level of myopia?
It would depend upon the level of myopia, the posterior depth that you go to, because the anterior depth can be prefixed. The posterior one would depend upon how much myopia and with what zone are you trying to correct. So it's going to be much deeper.
Okay, thank you.
Thank you very much. Rupal, it's been a pleasure. Have a safe trip back to India. Thank you.